So, good evening, everyone. A very warm welcome to Critical Care Conversations, a platform where we bring direct insights from global experts and guideline authors, translating evidence into real world practice. Today's session is particularly special as we discuss the recently released Surviving Sepsis Campaign 2026 guideline, a long awaited, highly anticipated update. I'm Dr. Bharat Jagiasi, joining you from Mumbai, India, and I have the privilege of moderating this esteemed session. To begin with, we have a keynote talk by someone who needs no introduction in the world of sepsis research and guidelines. It's my absolute honor to introduce Dr. Hallie Prescott, Professor of Pulmonary and Critical Care Medicine at the University of Michigan. She has been the forefront of sepsis research and, most importantly, lead author of the Surviving Sepsis Campaign 2026 guideline. Her work spans epidemiology, outcomes, and implementation. Professor Prescott, thank you for joining us today. We are all eager to hear from you on the highlights of the adult SSC 2026 guidelines and how we can translate them into meaningful clinical practice. Over to you, Hallie.
Wonderful. Well, thanks so much for having me today. I'm going to go ahead and get my slides loaded. All right, hopefully you are seeing the right thing. So I am going to cover key highlights from the guidelines today. I have one financial disclosure. I'm a consultant for Aerobac Therapeutics. They have nothing currently on market and nothing addressed in the guidelines. So I will touch on the panel composition, the methods for guideline development, and then I'll highlight key things that are new, changed, or same in the 2026 guidelines. So the 2026 panel was a truly international panel. We had 69 members coming from 23 different countries, and 38% of this panel either currently or previously has practiced in a lower middle income country. Panelists were assigned to one of 6 working groups here to address screening and early management, infection, hemodynamics, respiratory support, additional or adjunctive therapies for sepsis, and then goals of care and long-term outcomes. Within each subgroup, there was a methodology lead, and we had at least one member who practiced in a lower middle income country in each subgroup, and the vast majority had multiple. There was a formal systematic review team that did the evidence search and synthesis, and then we also had a patient and family advisory panel. Oops, there we go. All right. So in terms of the methods, we followed structured processes that are standard for trustworthy clinical practice guidelines. First, we developed the questions to address and define those using a PICO format, so defining the population, intervention, comparator, outcomes of interest, and then prioritizing those outcomes. They then did a systematic review, and that was done with research librarian and then with close interaction with clinical experts. We then extracted the data, did meta-analysis for the pre-specified outcomes, as well as subgroup analyses and risk of bias assessment. And then finally, we grade the certainty of evidence, and that's a formal approach using grade methodology that involves assessing the type of studies, whether these are clinical trials versus observational studies. And then there's a number of different factors by which we can upgrade or downgrade the strength of evidence after assessing the type of study. After that is done, so after we've done the evidence synthesis, we then use a structured process called the evidence to decision framework. And essentially, this is a worksheet that we fill out for each and every PICO question, where we together discuss the certainty of evidence, the balance of desirable and undesirable effects with the intervention, the values and preferences, which essentially means how important are the outcomes that are impacted by this intervention. We discuss the resource use, like how difficult is it to implement this globally, implications on equity, acceptability, and feasibility. And only after we've gone through each of those components do we then draft our recommendation. We have this new figure that's in the guidelines that tries to sort of peek under the hood of how we get to certain types of statements. So most statements are graded recommendations, and they range from strong recommendations, conditional or weak recommendations, conditional or weak recommendations against something, or strong recommendations against something. But at times, there is insufficient evidence. So in which case we make a statement of no recommendation. And so in this kind of fine print here, we discuss the different considerations that we review when deciding whether to issue a statement versus a statement of no recommendation. And that basically includes the certainty of evidence, whether a recommendation was issued on this particular topic in prior guidelines, whether the intervention is already available, and whether the intervention is already in use. So there's a lot of different factors that go into the decision of whether or not to issue a statement. Also in the guidelines, this is table 2, we have a table that talks about the implications of strong versus conditional recommendations, including the impact on patients and families, clinicians, policymakers, and researchers. Most of the recommendations are conditional recommendations, meaning that these are the kind of default practice, the rule of thumb, but depending on the clinical context, there might be reason to deviate from those recommendations. This also is an area where additional research is warranted and may change future guidance. So after we have drafted the statements for each of our PICO questions, we all came together and had an in-person meeting. This was held in March of 2025 in Chicago, where we had 2 days of in-person discussion about those draft recommendations. After that, the subgroups took that feedback and edited as needed the statements to largely to make sure that they are clear and communicating the intention. And then we went to 3 rounds of voting. So for a statement to show up in the guidelines, there had to be at least 75% response, and we, consistently got 98% or higher response on each of our 3 rounds of voting. And then there had to be at least 80% agreement among people voting on those recommendations. And I would say that the vast majority were greater than 90%. So what is in the guidelines? Here is a very high-level summary. There are 129 statements. As I mentioned, most of these are conditional recommendations, about 64%. We have a smaller number of strong recommendations and good practice statements. And then there were 11 statements for which we had insufficient evidence and were not able to issue a recommendation. So I'll walk through some of the key components. So first, for screening and early management, we can have a statement. This is carried over from prior years. Sepsis and septic shock are medical emergencies. Treatment and resuscitation should begin immediately. This remains a core tenet of sepsis and is not changing. We have a number of new conditional recommendations that are really all aimed around trying to speed up the diagnosis and treatment of sepsis. So first, we have a new conditional recommendation to screen for sepsis en route to the hospital. That means in ambulance or in air flight on the way to the hospital. And then we have a related recommendation, 21, to administer antibiotic therapy en route to hospital in very select circumstances. And so those select circumstances are if there is a very high likelihood the patient has sepsis, the patient is also hypotensive, and the patient has a prolonged transport time to hospital such that it's anticipated there's over 1 hour to in-hospital medical evaluation. So in those circumstances, we suggest that it's appropriate to initiate antimicrobial therapy en route to hospital. And then finally, we have a conditional recommendation to use code sepsis or sepsis huddle protocols. These are essentially protocols, I think, largely used in North America to date, but essentially involve some sort of trigger saying, we think that this patient may have sepsis, and that's either done by, a clinician screening for sepsis, or it's like some kind of automated alert in the health record, but some kind of flag goes off that says, this is a patient who may have sepsis, and it triggers the team to come together at bedside. And typically in a sepsis huddle protocol, that's the people already taking care of the patient. So that's often like the nurse in the emergency department, maybe a charge nurse, pharmacist, the physician, to come together, have a conversation to touch base. Do we think this patient has sepsis? And if yes, talk through what are the next steps. And it's, again, trying to get everybody on the same page and expedite the next steps in care. And then in a code sepsis protocol, this is sort of similar, but often involves kind of maybe a dedicated team, like a rapid response team, or some hospitals even have dedicated sepsis teams. So that is a conditional recommendation to try to speed up and expedite early recognition, confirmation of the diagnosis, and initial management of sepsis. All right, the next recommendation I'll highlight, this is one that is the same from prior guidelines. So for adults with sepsis-induced hypoperfusion or septic shock, we suggest administering at least 30 mLs per kilogram of intravenous crystalloid within 3 hours. And that should be based on actual body weight, or in a patient who is obese based on adjusted body weight. And so we have a table that's new in this guideline that shows how much fluid that is depending on the weight and the height of your patient. And so you can see that for adults, this is often around 2 to 3 liters of fluid. And then when you consider the sort of full range, about 1.5 to 3.5 liters. We have included a number of new remarks about this statement. So first, consideration should be given to individual patient characteristics and context when selecting the initial fluid volume. So again, this is a conditional recommendation, which means that there may be reasons that you'd want to deviate from that initial fluid volume. We have an additional remark that clinicians prescribing fluids should perform frequent ongoing reassessment and closely monitor patients to avoid harms of over or under resuscitation. And then a remark that fluid volume should be calculated on the actual body weight or adjusted or ideal body weight in obese patients. So there's a lot more language about, again, recognizing that this is a conditional recommendation and, trying to acknowledge that there are important clinical reasons by which you might deviate from that initial fluid volume. All right, next I will highlight a statement of insufficient evidence, because I think this is sort of an important area for future research. So there's been a number of new rapid host diagnostics that have come onto market recently, mostly because they've been shown to be accurate against some reference standard for sepsis, but there's essentially little or no data thus far on their impact on processes of care or outcomes of care. And due to that, we have an insufficient, a statement of insufficient evidence. And I'll just sort of highlight some of the considerations. This is text taken from the narrative. We say, due to the costs of these diagnostic aids and lack of evidence that they improve patient-centered outcomes or resource use, we did not issue a recommendation for any of these specific diagnostic aids. Studies evaluating the impact of these diagnostic aids on patient outcomes and resource use are a research priority. And for that reason, it's reasonable for health systems and clinicians to make use of them where feasible, but to study their impact on patient outcomes and resource use. So I think this is a very clear need for future research to understand when and how to implement these tools into practice. All right, next I will move on to highlighting some key recommendations within the infection control section of the guidelines. So for antibiotic timing, these statements have minor changes, for clarity and wording, but otherwise the intention is completely the same. So a recommendation to administer antimicrobial therapy immediately in patients with shock who have possible, probable, or definite sepsis, ideally within an hour of recognition. Whenever you have, essentially confirmed that the patient has sepsis, administer antibiotics immediately, ideally within an hour of recognition. And then when sepsis is possible and the patient is not in shock, we recommend a rapid assessment of infection versus non-infectious causes of illness with a goal to administer antimicrobial therapy within 3 hours if concern for infection still persists. So again, completely consistent with the 2021 recommendations. We do, however, have a number of new conditional recommendations that focus on tailoring the selection of antibiotics. And I would say that just in general across these guidelines, there's been a greater focus on antibiotic stewardship. So first of all, we have new conditional recommendations on the use of anti-anaerobic coverage, and these are 2 paired statements. So we suggest an empiric regimen without anaerobic coverage in patients who don't have risk factors, and largely that is patients whose site of infection is lung or urine. The chances of that being due to an anaerobic pathogen is exceedingly low, and where possible, anaerobic coverage should be withheld. By contrast, we have a conditional recommendation to include anaerobic coverage in the empiric regimen in patients with risk factors. So this includes sites of infection such as interabdominal, obstetric, or necrotizing soft tissue infection. Another recommendation on the same vein of thinking about the empiric selection, we have a conditional recommendation against empiric antifungal therapy. In the prior guidelines, we had a paired statements, a conditional recommendation for and a conditional recommendation against, depending on the risk level of the patient. This has been revised really in recognition that it's a very sort of rare cause of sepsis, and even in studies trying to identify patients at high risk, very few patients ultimately end up having fungal infection, and that studies have not shown benefit of empiric antifungal coverage. So this is now basically shows up in a remark that empiric antifungal therapy should be considered on a case-by-case basis for selected patients at very high risk. So essentially trying to align the recommendations with how often you might use this in practice. So most of the time, we suggest against using empiric antifungal therapy outside of case-by-case considerations. All right, the next suggestion I'll highlight is a recommendation that has been upgraded from conditional to strong recommendation, and that is for the use of prolonged or continuous infusion of beta-lactams for maintenance therapy after the initial loading dose. This is based on high-quality data. So there's been a number of randomized clinical trials, and including the BLING-3 trial, which was published since the last guidelines. So due to additional accruing clinical trial data showing mortality benefit, this was upgraded from a conditional recommendation or a suggestion to a strong recommendation. Additionally, this is another recommendation that has been upgraded, and this is a recommendation to de-escalate or either narrow or stop antimicrobial therapy in sepsis after the culture results have come back. And this has been examined in a number of different studies and is associated with improved clinical outcomes to sort of minimize or limit unnecessary antibiotic therapy after the cultures have returned. Next, we have a number of recommendations related to source control. So we suggest that patients be rapidly evaluated for specific anatomic diagnoses or sources of infection that require emergent source control. And new in this guideline, we have a time-based suggestion that that source control be done early over later, ideally within 6 hours where feasible. All right, I'm going to move now to hemodynamic monitoring and resuscitation. New in this guidelines, we have a master figure that summarizes the recommendations related to hemodynamic management, and this is organized into 3 pillars: one for monitoring of patients, one for fluid therapy, and one for vasoactive agents. So this figure is intended to be applicable for patients with sepsis who present with either hypotension and or lactate elevation. We recommend that patients have monitoring with an initial lactate and capillary refill measurement. We suggest an initial fluid volume of 30 mLs per kg, and that be balanced solutions. And then for vasoactive agents, we recommend strong recommendation to use norepinephrine as the first-line vasopressor, and a suggestion that it's okay to initiate that peripherally as opposed to through central access. You'll see here that the recommendations in green with 1 check mark, those are conditional recommendations, and the 1 strong recommendation is shown in the darker green with 2 check marks. So those are really the sort of initial managements of the patient. And then for patients who continue to have ongoing hypotension or lactate elevation after the initial fluid resuscitation, we have recommendations related to ongoing monitoring, additional fluid to be guided by fluid responsiveness assessment testing, and then suggestions for additional vasopressor therapy, as well as use of corticosteroids. In terms of sort of changes to guidance. We have a new conditional recommendation to use either invasive or non-invasive blood pressure monitoring. This is a revision from the prior guidelines, which had a suggestion to use invasive blood pressure monitoring for patients in shock with an arterial line. This was revised based on essentially limited evidence showing that use of invasive blood pressure monitoring across the board impacts outcomes. And recently, the EVERDAC trial was published showing essentially equivalent outcomes between using an invasive strategy versus an initial non-invasive strategy, with an upgrade to invasive strategy only if sort of certain safety criteria are met. And so we do include remarks about specific scenarios where we do suggest use of invasive monitoring, and that's on patients with intermediate to high dose vasopressors, escalating doses, multiple vasopressors, frequent arterial blood sampling, or if there is difficulty having consistent measurement with non-invasive blood pressure monitoring. And so I would say that in general, this conditional recommendation is sort of acknowledging that there's a lot of patients who end up on low doses of vasopressors and they're weaned off within a couple of hours. And probably many of those patients could avoid having an arterial line placed. But certainly for our sicker patients, multiple escalating vasopressors, the suggestion is to use invasive monitoring. All right, next, I'll highlight this recommendation that has been upgraded in terms of certainty of evidence. This is a suggestion that for patients with sepsis or septic shock, to use balanced crystalloids such as lactated ringers over saline. And the certainty of evidence is now moderate certainty. We have a number of clinical trials and the overall body of evidence suggesting a mortality benefit in patients with sepsis. We do have a remark, a specific carve out that for patients with sepsis who have traumatic brain injury, to suggest using saline, again, based on clinical trial evidence suggesting that saline is preferred solution in brain injury patients. All right, this next recommendation is about using dynamic measures to guide fluid resuscitation after that initial bolus of about 30 mLs per kg. And this includes using things like a passive leg raise test to look for changes in stroke volume or cardiac output with passive leg raise or with a test bolus. And this has been upgraded from very low to low certainty evidence. So I think in general, we still need more data to guide resuscitation and sepsis, but there is accruing data suggesting, clinical outcome benefits to using dynamic measures to guide ongoing resuscitation. I'd like to point out that there's a number of different areas in the guidelines where we continue to have low certainty evidence or really insufficient evidence to make a recommendation. And so for 13 different of our clinical questions, we included a panel survey where we provide direct report of what people are doing in their own clinical practice. These are not intended to be recommendations, but really trying to give more information for areas where we have really little evidence to guide practice. So you can check those out in the guidelines. I'll close by pointing out a few different resources that are available. So on the Surviving Sepsis Campaign website, there is now an interactive feature where you can filter the recommendations. So you can click on all the different sort of questions and it will take you right to that recommendation. Additionally, there is a new phone app. This is the SCCM point of care app that you can download for free. And this currently has the 2021 guidelines, but I have been promised that the 2026 guidelines will be released onto this app later this week. So again, providing sort of filterable, kind of easy to navigate way to check the recommendations. So with that, I will wrap up and we can move to questions. Thank you very much.
Thank you so much, Hallie, for that incredible, insightful, and structured overview. So this was not just informative, but was exceptionally clear and insightful. Thank you very much. We now move on to what I believe will be the most exciting part of today's session, panel discussion with the guideline authors themselves. Just allow me to share my slides, please. One moment. As we know, we joined by the authors of the guidelines themselves, and already Hallie Prescott has been introduced. He's professor of pulmonary and critical care medicine, and she was the lead and first author of the SSC campaign guidelines. Then we have Professor Daniel Lee Baker, past president of ESICM Global Authority on Hemodynamic and Sepsis. We are joined by Professor Sheila Myatra, past president of Indian Society of Critical Care Medicine, chair Intensive Care Medicine Committee of WFSA, immediate past president All India Difficult Airway Association, and she is the one who developed a new test in hemodynamic monitoring called the tidal volume test, tidal volume challenge, published in CCM in 2017. Then we have Professor Bram Rochwerg, vice chair SSC, leading expert in clinical trials and guideline methodology. He's professor at McMaster University. So before we dive into the specifics, I would like to start with a broader perspective. Hallie, first of all, congratulations to you and the entire team for delivering these much awaited guidelines. So putting together such a comprehensive document with so many global experts is not a small feat. We all know that. So can you share your experience of working with such a diverse and highly accomplished group? How did you achieve consensus and what were the biggest challenges?
Yeah, thanks. It was a true honor. Our panel was completely awesome, and I thought worked incredibly well together. So I think, it's a large panel, so it was quite helpful to be into 6 working groups where you would have more sort of close and regular interaction. And most of the panels, the subgroups, they met about every 1 to 2 weeks during the sort of heavy parts of the guideline development. And then Massimo Antonelli was the other co-chair with me, and the two of us would try to have one or the other of us attend each of those subgroup meetings wherever possible to kind of stay abreast of what was developing, what were the conversations in the subgroup, and also sort of share thoughts across subgroups. And then I thought that the in-person meeting was incredibly valuable. Sometimes it's hard to focus online. You're checking your email, you're doing other things, but bringing everybody together in the room in person, I thought we had really fantastic discussions. And, people had just very different perspectives, depending on whether they practice emergency medicine and critical care, different countries. And I think guidelines are just way stronger when you have all of those voices at the table and we think about sepsis from kind of all the different perspectives of how it's managed across the world. So yeah, just incredibly grateful for our panel and everybody's willingness to put in the hard work and share their experiences.
So yeah, well done and congratulations to all of you. So let's start with the discussion and we have the questions coming in and those are part of many questions what even I have. So I'll take it accordingly. So question number 1 is to you, Hallie. We all know sepsis recognition remains one of the biggest challenges. And given the limitations of Q so far, are we moving towards dynamic risk stratification using early warning scores like news as 2? Is there enough evidence to support routine sepsis screening in pre-hospital care?
Yeah, so gosh, sepsis screening. This is a challenging topic because I think this is one of the things that truly there's huge variation across the world and even across individual states like Michigan in terms of how people do this, and probably no one right way. I think all of these different screening tools have kind of variable sensitivity and specificity for sepsis, and then variable sensitivity and specificity for picking up the highest risk patients at risk of mortality. And so when we think about screening, I think a couple of things that you want to consider is one, how easy is it to implement your screening tool? So there's something to be said for simple, easy to calculate tools. And then the second is what happens next? Okay, that's incredibly important. Your patient screens positive. What are you going to do? You could have the best screening test in the world, but if no one's responding to it, it really doesn't matter. And I think to me, the study that sort of really hit that home for me was the SCREEN trial, which was a cluster randomized trial and used QSOFA, which we know is not particularly sensitive for sepsis. Only picks up, maybe a third of patients with sepsis. But they had a very clear-cut effector arm, right? So they, it triggered that people came to bedside, they initiated next steps, and that was, in the cluster randomized screen trial, shown to have a mortality benefit, right? So I think that the screening tool is just kind of one piece of your overall sort of sepsis response picture. But in terms of, yes, if I had to pick one myself, I do think that there's probably accruing evidence that News 2 does it's more sensitive. It's going to flag positive more commonly in patients with sepsis. And it also does a good job of picking up those sickest patients. So in terms of looking at the kind of like area under the curve for mortality, it does pretty well. It's not specific to sepsis, right? It picks up people with clinical deterioration or clinical instability. So you kind of have to ask the next question of, okay, yes, my patient is flagged positive. Do I think that that is due to sepsis? And that's where those huddles can be helpful, right? Patient flags positive, you come to bedside, you talk, discuss amongst yourself, get more history, try to distinguish, is this due to infection? If yes, move forward with sepsis treatment.
Yeah, thank you.
And then, yeah, go.
No, please continue.
Oh, well, I was going to move on maybe to the second question about, is there enough evidence to support routine sepsis screening in pre-hospital care? Yeah. So I think that we reviewed the literature on this. There's not a ton of studies, but there are some studies suggesting benefit. And then we think about that entire evidence to decision framework, right? Like, how costly is this to implement? Not that costly, right? How feasible? Pretty feasible, right? And so it's when you consider all those things together. So I would say that, the easier something is to implement, the more likely it is to have a potential large, impact, the better. So yes, our overall assessment is that yes, we suggest initiating this screening pre-hospital. There's a number of different tools available. We're not able to make a recommendation about which one of those is best. And so I think that the specific tool could be, tailored to the location. But I should maybe let my other panelists chime in with their thoughts too.
Thank you. I had a follow-up question as well, but I'll come back to you again if the time permits. So, Professor Daniel, welcome to this webinar, and thank you for making it up for us. So, as we understood, we have traditionally anchored resuscitation around a map of 65. This is what we've been practicing now since many years. But should we now individualize target based on microcirculation or pre-morbid physiology, and especially in case of elderly, where we thought of mostly they are hypertensive patients, CKD patients, we thought maybe having MAP on the higher side would be better in those cases. But the guidelines have proven in other way. In elderly patient, they have allowed permissible hypotension. Is that acceptable?
So to begin with, I'm not a panelist. I mean, I'm indeed deeply involved in the Surviving Sepsis Campaign, because indeed I'm the co-chair of the steering committee. So indeed, I'm involved in the guidelines, but not as a panelist. And you highlight here one of the complicated aspects that the guidelines have to really do, which is indeed making a recommendation where the studies are not that straightforward. So we have a lot of data from observational data that indeed the cutoff is there around 65. But of course, we all agree that when you need to treat hypertension, you also use drugs that can provide some adverse effects that are often dose dependent. So if you want to reach a higher threshold, you probably need to have a higher dose, especially in sepsis where the patient are hyper responsive. And so this will be one of the key problems, is to know exactly what is the best blood pressure target for a given individual. And so if we just rely on the MAP target, and I will answer first the second part of the question, it's really a complicated aspect, because indeed, this is based on one trial, basically, the La Montagne trial, added with some others, but this was indeed in the elderly. It was indeed that trial, even though we have to admit that a lot of elderly patients were also included in the other trials, but this was, let's say, purely on elderly. And what is indeed this low value is a little bit complicated to know, because indeed this was a target 60 to 65, but it was not achieved in 75% of the patients who were higher than 60 to 65, even in the target group. So at the end, these trials do not do exactly what they have to do, because indeed the target was not exactly there. The panel was very wise to add and I'm not so sure that Hallie mentioned it here, but we have already discussed it so many times that indeed we know that achieving a precise value is very complicated. So it's a ±5 that is accepted there, and I think that that's a key element of the recommendations, that indeed it is something around that value. And so if the patient is well with 63, well, there is no reason to try to indeed push harder. And so the real question will be at some point to define what is well and what is unwell. And for that, you mentioned here microcirculatory status, pre-morbid physiology. Microcirculation, I would go, of course, not for the true visualization of the microcirculation, because it's very complicated, not really feasible, and especially not is a timeline that is discussed here, which is initial stabilization. However, we may have some surrogates like the capillary fill time. And for that, I think that the data from the Andromeda 2 shock trial were going in that direction also. If you have a normal capillary fill time, you just follow your patient. You don't have something else to do. So I think that indeed you need to use this kind of easy clinical tools to try to identify if your patient is more or less in a relatively good state. And again, I think that if your patient is not sedated, that's easy also to look at the brain function, because this is something that can be assessed clinically also. And of course, if it is not adequate, then you can do a test. Just try to increase transiently the blood pressure to see whether it improves the problem you want to fix. And if something is not going good there, just go back to the previous one, which was probably the best achievable with a lower cost aspect. I don't know if you have something to add to that, Hallie.
Hallie?
No, I think that sounds good. Yeah.
Yeah. So
sorry, I've been answering questions in the Q&A over
doctor,
here.
You're helping me out. Thank you for that.
Sorry, I didn't know that.
So we'll move on to our third question, and that is for my mentor and guide, Professor Sheila. So fluid resuscitation, ma'am, welcome, and thank you for accepting my invite and helping me in arranging all this. So fluid resuscitation, we know that continues to be debated, and I know you being part of two diverse group, one saying 30 ml at least per kilogram, that is, and another one says up to 30 mils per kilogram. So even you being part of two groups, which are the two different kind of recommendations, and then we have a senior leader from our ICCM, Dr. Kawal, also asking why this, in spite of not being enough RCTs, are we, because this was a recommendation we're looking to change in the coming days, but this is what I would say most were disappointed having the same kind of maintaining a status quo.
Yeah. Thank you, Bharat. Firstly, thank you for having me here, and congratulations and thanks for putting this team together. So I agree with you. This 30 mils per kg has probably been one of the most controversial recommendations, as in most discussed, and it's generated a lot of heat, especially in our part of the world where, in low resource settings, especially where they're always concerned about giving large volumes of fluid, especially with the shortage of ventilators and things like that. But if you have to look at the recommendation, people just look at 30 mils per kg, but you have to look at it more carefully. And it's a suggestion, and it's also a conditional recommendation with low certainty of evidence. And it's over 3 hours, up to 3 hours. So it is not that you have to give 30 mils per kg in 10 minutes or 15 minutes or something like that, right? So, and it has been downgraded from a recommendation to a suggestion in the previous iteration. So this was revisited. It's based on a retrospective study, and I agree with you, some observational data. But if you even look at trials like the ARISE, PROCESS, and PROMISE, the big randomized controls that were done, even pre-randomization, the volume of fluid that was given was close to 30 mils per kg. But what I really like is the way in the guidelines they've given some remarks. So it's not just a statement, but there are remarks. You have to also contextualize this. You also have to look at the patient characteristics. So if I have a patient, for example, with severe ARDS or a very weak heart, I'm not going to push 30 mils of fluid to this patient. I can always give some volume. I can look at the effect, and then I can decide on giving a larger volume of fluid. So I think those kind of remarks below each of these statements, I think is really helpful. And Hallie already showed the table. So it's 30 mils per kg actual body weight, but once the BMI goes more than 30 kilograms per meter square, then it is based on actual ideal body weight. And there's a very nice table that is also given in the guidelines. So of course you could individualize subsequently, and you could look at the fluid responsiveness, which Hallie's also talked about, and then decide about giving more fluid. Regarding using so this is the recommendation that is
lactate is also being asked by Dr. Kawal. So I mean, as you said, it's come to the guidelines. Why lactate guided resuscitation prioritize over clinical examination, CRT, what we been practicing, and any evidence that lactate improves clinical mortality?
Right. So this is again another suggestion, and it has been carried forward from the last iteration. So I know capillary refill time has become very popular, and now after the Andromeda shock too, and I'm also a big fan of capillary refill time. But a lot of people, they work in different ways, lactates and capillary refill time. So a lot of people think that they are interchangeable, and they think, oh, that if I'm using capillary refill time, I don't need to use lactate. I think that that's not a right approach. You use lactate, and you can, your lactates can be elevated because of increased production, because of decreased clearance, and you can complement it with the capillary refill time. So I use both in my clinical practice. So again, the suggestion is not to normalize the lactate, but decrementally you monitor it and you look at decrement. So I think together in conjunction, this can give you very useful information to guide your resuscitation. So I don't think we should say absolutely no to capillary refill time or to lactates, and both can help you guide your clinical resuscitation.
If I may add,
Yeah,
I mean, remember that in the Andromeda 1 trial, which really compared lactate guided, CRT guided, the inclusion criteria was to have an elevated lactate. So it doesn't discuss patient with normal lactate levels and their capillary refill time. It really goes with patient with elevated lactate, and then of course you can follow both. And the most interesting aspect there was that lactate decreased more rapidly in the capillary refill time targeted group than in lactate 1, just because indeed they estimated capillary refill time every 30 minutes. While for the lactate, there were only actions every 2 hours. So probably lactate keeps its value. The problem is that the time intervals, and sometimes also the fact that we also use some drugs that can also artificially increase lactate. So we need to be more clever and more cautious with lactate, but probably if you having lactate is something very important and very useful.
Agree. Thank you.
And this is where the question came in: why are we still recommending lactate? So yeah, I'll move on, and Professor Daniel, again, it's for you. So we all know crystalloid remains a first line, and of course, in case of the TBI, as Hallie introduced, but the albumin question still persists. And so, in which clinical scenario do you think albumin truly adds value in septic shock, and why is this recommendation crystalloid alone over crystalloid versus plus albumin?
Well, the issue is that we do not have a clear answer. I mean, if we look at large-scale randomized trials, we have no penalty using albumin except the cost. And of course, if we accept the brain patients, brain injured patient, but otherwise, it's not dangerous to use albumin. It's very costly in most of our areas, and the question is to know exactly when do we have a good indication for it? The actual Surviving Sepsis Campaign retained as a remark that yes, when you give a lot of volume, then it may still be reasonable to consider albumin at some point. I would like to add, of course, if you have hypoalbuminemia, I guess that this will be a prerequisite, but it still remains reasonable and close to what the people in at least my environment are doing. So it's very complicated because I do not have good data to say that we should do that differently, and also to say that what we are doing is the best way to do. It's just that we still lack data for that. It's clear that correcting hypoalbuminemia for just correcting it when you have no other issues doesn't help a lot. But if you're a patient with impaired tissue perfusion and you need to give volume and you have hypoalbuminemia, and in addition, you have indeed a little bit wet lungs, well, maybe albumin could be a good compromise in these conditions. But we do not have good data, and we have no good data to exclude its use. So it's just that it's based mostly on lack of expert opinion on the way the literature is going in one direction. And I think that is reasonable, but not sustained by many data.
Yeah, thank you. So hi, Bram. Good morning to you, and thank you. I am glad you made in time. So I had planned your question a little late because I knew you had some prior commitment. So we often escalate vasopressors stepwise, and so is there a case for earlier combination therapy with norepinephrine as the first line? Are we underutilizing early combination of vasopressor therapy? Is any physiological rationale for vasopressor initiation than escalation based use?
Bharat, thanks so much for the invitation to join this morning. My absolute pleasure to be able to participate always, and great to collaborate with Indian colleagues. And, it was such a pleasure to be involved in this guideline under Hallie and Massimo's leadership. It was truly remarkable experience. And I agree with Hallie, such a great and engaged panel. Really, really fantastic to work with. I served on the hemodynamic panel where we addressed this question around optimal vasopressors. And I like this recommendation because it aligns with my practice. I think a lot was made of vasopressin and its role both on systemic vascular resistance, but also on the renal selective effects as well. And, many trials that looked at perhaps the role of vasopressin to optimize kidney function as well as blood pressure support. And you'll be aware some of those like VAS did not show the benefits that folks might have thought as a first line agent. However, the idea is that, vasopressin working on alternative receptors to the adrenergic receptors, perhaps being able to decrease that beta adrenergic drive might get away with less tachyarrhythmias. And that's what a lot of the trials have, when you especially pool amongst the RCTs, probably we saw a potential signal for a reduction in mortality when adding vasopressin to norepinephrine, but most importantly and very clearly, a reduction in tachyarrhythmias when adding vasopressin earlier as well. And so, this tends to be my practice, is the early introduction of vasopressin as an adjunct to norepinephrine. And I think over the years, we've seen the recommendations slowly sort of increase in certainty and increase in strength, perhaps dropping that threshold when we might initiate. And I know now in the verbiage and discussion, we talk around 0.2 mics per kilo per hour in terms of dose of norepinephrine. And again, very consistent with my practice that I use it earlier and earlier these days.
So you still believe starting with norepinephrine is a good idea and then we escalate to the vasopressin?
Absolutely, I do. And that's consistent again with our recommendations, in which we offered a strong recommendation. And again, when you look at the head-to-head trials, there's not a clear signal for benefit with looking at an alternative agent to norepinephrine. So I do start with norepi. But again, my threshold in my own practice and consistent with the recommendations in the last few years is that threshold for adding vasopressin has dropped. It used to be in the past, I'd wait till I was on moderate doses or maybe 0.5, 0.6, higher dose of norepinephrine where I'd add in the vaso. And I knew that the trials didn't show difference, but you know what? It made me feel better. I was getting away with lower doses of norepinephrine and it made me feel better. But this data, again, showing a reduction in tachyarrhythmias. I think AFib is important to our population. There's an increased stroke risk. There's management that goes along with tachyarrhythmias. And if I'm able to decrease that risk of tachyarrhythmias without, most importantly, Brad, without harm, no signs that it increases limb ischemia or bowel ischemia, then I think it's justified. An important consideration is that not everywhere has availability of vasopressin. And if that's the case, that's the case. And some of what influenced this conditional recommendation. But if it is available, cost is not a concern. I do think that there's benefit.
So here I'll take a question from the audience. So we have Ramchandra Venu and Saroj Patnaik asking, when do we add steroids, and only hydrocort or plus two, or you have to add the flutocortisone as well over there?
Maybe other members of the panel have strong feet on this. This is an area that I'm passionate about for sure as well. When I think about, maybe when I was a trainee, I thought about adding corticosteroids in the setting of septic shock, mostly around relative adrenal insufficiency. But I'll tell you, my rationale for administering corticosteroids has evolved over time. And maybe there's a component of relative adrenal insufficiency, but also we know how much a sepsis is dysregulated immune response. And so my rationale for administering corticosteroids in the setting of septic shock is around also that idea of dysregulated immune response. And so, it's hard to peg down an exact dose of vasopressors, but my threshold, similar for my threshold for vasopressin, has decreased. My threshold for corticosteroids has decreased over the years as well, and I'm much more aggressive with the use of corticosteroids in the setting of septic shock. We've done meta-analyses, and it was referenced within the guideline as well, is that it doesn't really matter which steroid is used. There's studies that have looked at hydrocortisone, methylprednisone, others, and it seems like corticosteroid exposure in the setting of septic shock more important than the agent. But I'll tell you, of the 50 RCTs that have looked at this, the vast majority have used hydrocortisone. So it tends to be what I use, but I acknowledge that it probably doesn't matter as much. Maybe others on the panel have other feelings on this. I want to make sure we recognize.
Wants to add something? I'll move on. So everyone agrees with you, Bram. So I'll move on, and ma'am, this is for you, Sheila, ma'am. So monitoring strategies are evolving, and we all know, should arterial lines be mandatory early in all vasopressor patients? Can we rely on non-invasive monitoring initially as well?
Right. Interesting you asked this, and this is in this iteration, this has been revisited, the use of the arterial line, and it's changed from the previous recommendation where you may use non-invasive or invasive blood pressure monitoring. Now that also is something that can has really raised a lot of brows, because at least in the our practice, the moment you go on a little higher doses of vasopressors, you have to have an arterial line in place. But if you look at the studies, of course, observation data, but Hallie already talked about the EVERDAC trial. So it's a non-inferiority study, more than 1,000 patients, showing no difference in mortality when non-invasive or invasive A-lines was used. So I think based on the evidence, this is, again, it is a conditional recommendation, low certainty of evidence. It's a suggestion. But like I mentioned earlier, there are a lot of remarks. So it cannot be that, if you say no, non-invasive, that means I will just never put an arterial line, or I will always put an arterial line. So you really have to contextualize it. And that's what the guidelines, have in the text, if you read what they've given. So, of course, in patients who are going with intermediate to higher doses of vasopressors, or rapidly escalating vasopressors, or those patients who are very sick, of course, we would consider using putting an arterial line. But the practice of putting an arterial line in every patient in shock, perhaps we need to really, tone down on that a bit, because that may not be practical. And observation studies have shown more complications in those patients all those patients who've had, where we have the practice of routinely putting arterial lines in all patients. So this is something that's revisited, and I think we really have to contextualize it to decide either way.
So we had a question in chat box when Hallie presented, ma'am. She said in the mild to moderate doses, you can avoid it when it goes to moderate to severe doses. So what do you mean by mild to moderate and moderate to severe? When exactly is that? Sheila, ma'am.
So I don't think you can really have any specific cutoff like that. But if you see it's rapidly escalating, or you're on very high dose, 20, 30 mics per kg or something, you're going really high, then I would personally, because of my personal practice, I would be very uncomfortable managing this patient without an arterial line, because we know, and especially when your NIBP, non-invasive monitoring, is inconsistent. And we know in low and high flow states, non-invasive blood pressure may over or underestimate this. So in this kind of situation, I would definitely want to put in an arterial line. But I have also stopped putting arterial lines in all patients, as I used to earlier, all patients of shock. That was our practice. It was like across the board, you have a patient in shock, you must have an arterial line in. So I think that can, you can contextualize it to the, and, have a little more balanced, practical approach. And I think that recommendation serves. And again, it's a suggestion. So, you can use it according to your practices. You can taper it. Yeah, titrate it.
Yeah, thank you.
So, if I may add,
yeah, please.
There is still a point there where we need to be cautious. I mean, the concept is okay, and I think that it's again, it's aligned with what we all do at the bedside in many instances. The problem is that we need to look at the data, and do the data support this or not? Well, that's much more complicated, because indeed, observational trials are often confounded by severity. I mean, when you put a line, it's often because the patient is more severe than when you don't put it in a line. And if you look at the randomized trial, the major issue is that if you just look at the headlines, you say, okay, it's safe to delay, you have no problem. But then you need to look at the details. And remember that at least a lot of patients were excluded because they were not considered for being selected in that trial. And so among the 4,000 patients screened, only 1,000 were at the end included. And the reason for exclusion were multiple, but mostly severity, and also in some cases because the measurements were not reliable. And this is also something that is not easy to detect at the bedside. Is my measurement reliable, yes or no? So it's not always something that is easy to do. And the second aspect is, of course, do you need extra additional blood gases? And if you look again at this trial, it is really remarkable to realize that less than 2 blood gases per day were performed in these patients. So these were really very, very mild patients, because you can say, okay, they have central venous blood gas. No, they have no central line for most of the patient. So it was even not an arterial line, but also no central line, and so no blood gas at all. So, I mean, these are very not severe patients that were included. And so, yes, in these conditions, there is absolutely no reason to push for an arterial line, and we all agree for that. But we should not go in the other way around, telling, well, the study has not proven any benefit for an arterial line, so forget about the arterial line. This is exactly not what is said, and the guidelines are very clear for that, is that we need to have a look at the patient, and in some conditions, just as Sheila mentioned, when you have escalated doses, when you have other reason to have blood gases, you need to have your arterial line at that point. So it's really individualizing based on these remarks, but these remarks are very essential in these guidelines nowadays.
Yeah, thank you. Thank you very much for clearing it out. And thank you, ma'am. We'll move on to the next question. Request to all the panelists. When I mean panelists, is panelists of this webinar, not related to the sepsis campaign. So there are many questions, Q&As available. If you have time, you could answer it to them, because I won't be able to take all on board. So this is for you again, Bram. And we all talk about the golden hour, and the golden hour antibiotic concept is also deeply ingrained. So how do we balance urgency with the antimicrobial stewardship? And practically, should antibiotics begin in the embolus itself, as been said?
Yeah, thanks, Bharat. Also, great questions. And maybe I shouldn't. I logged on to social media in the last week or so, and there's always folks that are going to agree with guidelines and folks that aren't going to agree with guidelines is the bottom line. And a little bit of the folks that don't
Guidelines are to guide you. You don't agree or disagree with them.
Yeah, exactly. And a lot of the disagreement was around antimicrobial stewardship, which saying that, maybe we're too liberal with these guidelines on advocating for antibiotics for many, which I'm a bit surprised by, because I agree with Hallie. I think we did, they really prioritized antimicrobial stewardship as part of these guidelines, and moving to the importance of, giving antibiotics to the right population of folks, but also de-escalating and not using antibiotics in those that it's not going to be beneficial. And so I think in terms of the first point here, there's a lot of indirect data. And Ann Kumar, who's Canadian infectious disease doc and intensivist, did some of this early work demonstrating the importance and the mortality reduction associated with early upfront antibiotics in folks with septic shock. And so, we did say possible, probable, definitive that there's benefit in starting, and nobody's going to be doing randomized controlled trials, randomizing patients to getting antibiotics in the setting or not. But we do believe that there's a signal for benefit in this population. But importantly, Bharat, I guess, is that if you think that it's unlikely that a patient has sepsis, we're very clear recommended against empiric antibiotics. And I guess the other thing to keep in mind is, just because you start antibiotics in the early time period in a patient with possible sepsis doesn't mean you have to continue it in perpetuity. And I think, we were quite clear that if you started in somebody with hypotension that you think might be possibly sepsis related, but it doesn't turn out to be sepsis, or the pretest probability of sepsis or intra-test probability drops, there's nothing to say that you can't stop antibiotics, right? So I think it's reasonable in how we practice is to start up front as things evolve and see is that you stop. And again, I think we made lots of great recommendations around the use of empiric antifungals and using different tools and tests to try and decide when to stop earlier and reevaluating antibiotic use. So I think it's a difficult balance, one that we all struggle with as clinicians, this philosophy of not missing the golden hour, but stewardship. But I think that we tried to walk it. And to the second point, I also saw lots of folks that looked at this guideline and said, now we're advocating to give antibiotics to everybody in the ambulance. But if you read the recommendation, it's certainly not the truth, right? I think we said if there was a significant delay in transfer over an hour, I think was even the time limit that we used, you would consider using antibiotics. And it was a conditional recommendation, suggestion using antibiotics pre-hospital in the ambulance. So this is not going to apply in many jurisdictions where ambulance transfer times are shorter. But if there is going to be a significant delay, knowing that those with shock benefit from early upfront antibiotics with a demonstrated mortality reduction, this is a population that you might consider using.
Yeah, thank you. Yeah, we come back again to you, Hallie, and we're talking about the system level interventions are gaining traction. So do code sepsis programs truly impact mortality, or they improving only process metrics?
Yeah, I mean, great question. I would say that in general, a lot of these quality improvement or implementation type strategies, like the level of evidence on them is fairly low. They're often sort of single hospital, pre-post, right? We don't have, large scale, high quality randomized clinical trials. But I would say consistently, the data suggests that yes, they improve processes of care. And then we also know that these are processes of care that if you do them consistently, absolutely are going to translate into a mortality benefit, right? So I'm not convinced that we need to hold them to the level of, a mortality benefit if we know that getting antibiotics into patients with sepsis, speeding up resuscitation are also associated, with improved outcomes.
Yeah.
I think they're also helpful, even with patients without sepsis, right? Like typically these are triggered in like high risk SIPC patients. It's helpful to kind of bring people to bedside, rapidly evaluate, decide if this is sepsis or it's something else, right? This is a GI hemorrhage or, I think that there's little that can truly go wrong.
Don't they add on to the fatigue alert or alert fatigue, whichever we
Well, so this is where I think, you have to be mindful of like the entire intervention, right? So like the screen trial used Q-SOFA, and even though we know Q-SOFA is not as sensitive, maybe that's helpful, in certain scenarios because it's minimizing alarm fatigue and it's only flagging in the kind of, most helpful or like sort of the sort of like most sickest patients. And same thing like in the UK right now, they've implemented News 2 screening across their, entire, national health system, and they have a tiered response. So, depending on the score, there needs to be a bedside evaluation by the clinician, but the time that you have to complete that assessment is aligned with how sick the patient is. So like only the very sickest patients require like a prompt bedside assessment. So I think it's like trying to figure out what is the sort of tolerable level, right? Like we don't want something that like every 5 minutes is alarming in all of the patients because that's just going to drive everybody crazy and not move care forward. It has to be sort of tuned such that it's done in a way that it's feasible and actually improves care.
So, Bram, we've been talking about respiratory support strategies, and we all know those are shifting. So, should we be more aggressive with HFNC and awake proning to avoid intubation? Is that right?
Great question as well. Maybe I'll take the easier one here in terms of high flow nasal cannula. I do think there's great data to support the widespread use of high flow nasal cannula to prevent intubation. And I think we all gained an augmented comfort with high nasal cannula during the pandemic. Now, to be done in a monitored setting because patients on high flow perhaps look less sick than they actually are. And there's still all concerns about self-induced lung injury. And so I think these are patients we need to watch carefully, but certainly a role for high flow to avoid invasive ventilation. And I think we're all aware of that and consistent with the recommendations we made. Can I tell you the wake proning I think is controversial and maybe in this safe space, I'll be honest, this was one of the recommendations that perhaps in the entire guideline that I didn't love, but that's what happens when you get a big group of experts together is that you're not going to, even the panelists are never going to be happy with all of the recommendations, and that's okay. There has to be room to capture the evidence and the considerations that went into things. And so we did make a conditional recommendation for awake proning. You know, a lot of the data comes from COVID patients rather than sepsis-induced acute hypoxemic respiratory failure. I think we need more data outside of COVID, looking at the role of awake proning. There are benefits physiologically. There are challenges in terms of, you know, patient comfort. We heard from our patient. As Hallie and Daniel know, I chaired the patient family partnership group along with Lenny Durd. And we heard a lot from patients that it can be a little bit alarming to walk in and see their loved one lying on their stomach. It's not how you're used to walking in and seeing your loved one in a hospital bed. And so that was interesting to hear from the patient and family partners. So, you know, yeah, for now, I think there probably is more of a role for awake proning outside of COVID, but I certainly, this is one area where I think we need more data for sure.
Thank you.
Bharat, I think Daniel has to leave, so if you could ask the next question to Daniel.
Yes.
Yeah.
So, this is for you. Basically, we have the emerging therapies, and often from the suffer limited data. So, what is your take on the methylene blue and also the angiotensin 2 receptors? Is this indicate true lack of efficacy or simply a lack of adequately powered trials?
I mean, probably angiotensin is the easiest one because indeed you have one big trial which is considered by FDA to be a phase 3 trial, even though technically speaking it's a phase 2 with just increasing blood pressure as the primary outcome of the. Indeed, in that trial, the mortality was going in the good direction, but at the end, we do not have a lot of patients included in that trial, and that's it. For the methylene blue, so we really need more data. There is a good signal there, but we need more data to be really sure where to position this. And we're asking before to Bram whether you would like to have several receptors targeted, and the third one is of course angiotensin, and that's why it could be something interesting. So going the other way around with methylene blue, of course, we inhibit somewhat the action of nitric oxide, and the problem with methylene blue is that it has been around for a while, and the first trials in septic shock were in the early 90s, and at that time there were already good signals. Improving blood pressure and perhaps cardiac function, but bad signals, increasing myocardial ischemia and other signals like this. So if you look at the data, we really are lacking data. You have meta-analyses that are done, but these are putting together trials of 10 patients in each group, evaluated once in a while, more than 20 years ago. And sometimes it's also, you give once a drug and you look at mortality afterwards, after 28 days, but you don't know what occurs after this study. I mean, if I give you a product to my patient today, and I include this in a trial, I do not report what occurs tomorrow, after tomorrow, and so on. Sometimes people are treated more frequently with the drug afterwards. It's a placebo group than in the control group, intervention group. And so the so good trial are indeed the Mexican trial, where indeed there were some signals there. But again, we need to look cautiously at that trial because at the end, yes, it was using methylene blue in a dose that was different from all the other trials. And indeed, it was given for 2 days in patient mechanically ventilated, treated with vasopressin and norepinephrine. Half or 40% of patients were on renal replacement therapy. And the signal was a little bit too good. I mean, we need to have confirmatory trial because indeed mortality was indeed better. But also, if you look at the ICU length of stay is 7 days. 7 days when you are on 2 vasopressors, you had to add the third one, you had renal replacement therapy and mechanically ventilated. It's a little bit short, and 10 days in the hospital is also a little bit short for that. So either there was something confounding the intervention. I mean, too much sedatives or whatever, or there is something else that we need really to ascertain by confirmatory trials there. So that's why I think that we cannot say anything about the data there. There are some data, totally heterogeneous. Dose, time when the drug was given, an indication for the drug, and indeed duration of the exposure to the drug, so that indeed at the end it's very complicated to have a clear idea there. So we need more data, and it's really unfortunate to see that more people are using methylene blue than people studying methylene blue.
Yeah, thank you very much, and thank you for joining us, sir. I know you need to leave, so yeah, please, thank you. You can carry on. So my next question is for Sheila ma'am. It's for you. It's the post-resuscitation care is equally crucial. So what is the current stance on active de-resuscitation and fluid removal? Is active fluid removal recommended after the acute resuscitation phase? If yes,
Yes.
then when and how do we do it?
Yeah, so this is actually a recommendation I like very much, because we do a lot of acute resuscitation, and we're very aggressive at that point, and then subsequently we don't care too much
We
about
realize
active.
we've done something wrong and we de-resuscitate.
This is a new one of the new recommendations, talking it's again low certainty, conditional recommendation, low certainty of evidence, and it is talking about, it's a suggestion to actively remove fluid following acute resuscitation. And when we talk about acute resuscitation, you're talking about those patients in which you've given large volumes of fluid or gone up on vasopressors, and again, when you do this, there's also the remarks which you have to read very carefully. It doesn't mean that everyone for whom you've done acute resuscitation, you actively do fluid removal. So you have to look at what is the cardiac status, cardiorespiratory status of the patient. Is there edema? What is the positive fluid balance? What is the weight of the patient? So there are different things. You have to contextualize this, and it is not that you do it for every patient. So how you do it is, you start with diuretics, and if the diuretics are found to be ineffective, only then you could go on to ultrafiltration or extracorporeal removal. And if you look at the ESICM guidelines on fluid removal, also they suggest using diuretics, and they discourage against the routine use of ultrafiltration or extracorporeal fluid removal just to remove the fluids. And what's very interesting is that this recommendation had come from, as Hallie spoke, mentioned, that you have patient representatives also on the guidelines. So this particular thing was influenced by the patient views, that they thought that having looking very puffed up and having all this edema was something that they didn't like, and this suggestion was very much influenced by that. So I think we should also think about active fluid removal, just like we are aggressive with resuscitation. But of course, we have to be cautious about which patients we do it, and diuretics should be primarily used.
Yeah, thank you. And so we'll move on to the next, is about the selective decontamination, which remains a controversial point over here. So are there any ICU settings where acidity still has a role? If any, might selective decontamination of the digestive tract be considered appropriate? Because I think this has been an pendulum effect where we said yes, then again we said no, now again the recommendation has come in favor of it. At least for you.
Yeah, so I'm not aware that it was, this is not something that we've addressed previously in the guidelines, right? This is like one of those things where there's lots and lots and lots and lots of clinical trial evidence, but there hasn't been, I would say, big uptake outside of probably select countries in Europe. But, we try to answer difficult questions here in the guidelines. And so, this was prioritized because there is a lot of evidence. It's worth reviewing that evidence and seeing what it shows. And so, I think that the balance of the clinical trial data shows that at least during those places where it's been tested, it's associated with improved clinical outcomes. We made a recommendation about use of it in ICUs with low prevalence of multi-drug resistant organisms, and that was really about trying to think about the external validity, or where have the trials been done. I think yeah.
So
Bram, if you have anything else to add to.
Which patient to select, what to give, how much to give.
Well, I think it's not going to be an individual patient selection, right? This is like a unit-based intervention, trying to sort of control the development of like gram negatives in an ICU. So it's something that would have to be sort of decided, I think, at the unit level.
So, Bram, final question is for you, and this is given a significant proportion of SSC recommendations are based on low certainty, and as she showed, 64% almost. So, how difficult it is for the grade guy to ensure, particularly when the evidence is very weak, to give an appropriate grade and go for the Delphi consensus or the expert consensus? And how do we then balance also in between the studies available from expert consensus?
Yeah, it's a great question, Brad. As you know, I help as a guideline methodologist in other efforts than this one, and it's something we struggle with a lot. Even as a guideline methodologist, perhaps you'll be surprised for me to say, but evidence-based guidelines crucially involve expert input as well, right? That's why we have such a group of 80 experts that are in the room together, and properly graded evidence-based recommendations are a combination of the best summary of the evidence and the input from the experts in the room. And it couldn't function without both, And so I think that the idea that a lot of the recommendations that we generated as part of surviving sepsis are driven by low certainty evidence is a reflection that that's the reality of the world. And there's a lot of research still to be done. And I think one of the big impetuses from this work is to say, here's the research agenda for the next 5 years, 10 years, 15 years, and all the areas that we can improve upon so that hopefully the next iteration of surviving sepsis has stronger evidence around some of these areas. But even with low certainty evidence, there's a rule. I think the transparency and the rigor associated with following a process like GRADE is crucial. And, I worry about consensus generated Delphi recommendations moving back to that era of just the experts in the room saying this is the way we do things and this is the way everyone else should do things. And I think there's a lot of incremental benefit of having this systematic approach of evaluating the benefits of interventions, the harms of interventions, carefully considering the costs, input of patients' values and preferences. We went through an incredibly rigorous process for all 129 of these recommendations. And that's part of what takes so long and all the hard work that Hallie and others put in to get to where we are. So, I think I'm proud of the process that we followed. We tried our best to provide strong guidance where we could. When we couldn't, we recognized the balance and provided either conditional recommendations or no recommendations, but lots of room for further research to help advance the science around management of patients with sepsis to come.
Hallie or Sheila, ma'am, anyone wants to add something?
No, nothing. Thank you.
So we come to the end of this conversation, and first of all, congratulations to all of you. It's an amazing document, and these guidelines are not just a document, they are a framework for a better thinking, better decision making, and ultimately what we all look into is better patient outcomes. So thank you to all our panelists for such an engaging, honest, and intellectually rich discussion. I would like to thank Professor Hallie for her outstanding talk and her views as the questions came in, and of course to our esteemed panelists, Professor Daniel D. Becker, Professor Sheila Myatra, and Bram Rochwerg, and all of you, all the delegates and participants for joining us today. Thank you for being part of this meaningful discussion. Thank you. Stay curious, stay critical, and most importantly, stay compassionate. Thank you very much.